48. 48. The number of states where it is legal to discriminate against someone because of their weight and/or height. Let me repeat that. It is legal to discriminate against someone based on the size of their body in 48 out of 50 states. I want to come back to this, but first I'm going to pause to talk a bit about language. About 7 years ago, my then 6-year-old came to me and told me that she was no longer going to be drinking milk. I was confused. This was my child who loved a glass of milk with dinner and enjoyed it in her cereal in the mornings. So I didn't understand, and when I asked her, she explained to me, well, Mom, one of my friends told me that the reason that she is so thin is because she doesn't drink milk. So at age 6, my growing, developing kiddo was restricting milk to obtain a thin body. This is the moment I remember embracing the word fat in my personal life. So I'm going to use the word fat today to describe my own body and the bodies of others. Fat liberationists have been reclaiming this word much as we have reclaimed many words that have been used to harm folks in our society. Fat liberation scholars view fatness on a spectrum, all the way from small fat, which is about roughly a US women's size 16 or so, to super fat or infinifat, about a size 34 and larger. For reference, as a size 16-18, my body fits the small fat category. This affords me a great deal of privilege, of thin privilege, because, even as a fat person, because I don't experience the level of stigma and discrimination that someone in a mid-fat, large fat, super fat, or infinifat body experiences. You see, as you move along this fatness spectrum, discrimination and stigma increase, and participation to society decreases. You'll also notice that I avoid the terms obese and obesity, which I would be putting in air quotes where I'm not holding a mic. These words are highly medicalized and often used as a slur against fat folks, so it's best to avoid them altogether. So back to these 48 states. It is legal in almost every state to deny someone health care because they are fat. It is legal to deny someone housing because they are fat. It's legal to deny access to education because of one's body size, shape, or height. It's legal to fire someone, pay someone less, or deny someone a promotion because they are fat. For those of you from Michigan, where weight and height have been protected characteristics since 1976, you have legal protection from this discrimination. Those in Washington state have limited protection since 2019, and just last year in 2023, New York City passed landmark legislation. One place we commonly see weight stigma is in healthcare. Let me explain. Someone in a fat body has many opportunities to experience weight stigma in a healthcare visit. Not having furniture in the waiting room that will accommodate their body, weight stigma. Not having gowns that will fit their body, weight stigma. Blood pressure cuffs that are too small for their arms or exam tables that will not hold their weight, weight stigma. Flyers posted in the clinic for weight loss products, weight stigma. Providers focusing on their weight when that is not at all related to the reason for their visit, weight stigma. And the scale. Let's talk about weighing patients. What we know about weighing patients is that it is unnecessary and oftentimes harmful. We know from research that patients are avoiding healthcare, potentially life-saving preventive healthcare, to avoid the scale. People are avoiding healthcare to avoid being weighed. We also know that weighing folks is not medically necessary most of the time, yet we continue to do it at every visit. So perhaps we should shift healthcare policy to weigh patients at the end of a visit when it's deemed medically necessary. As a side note, did you know that you can refuse the scale at the doctor's office? Did you know when they ask you to get on the scale, you can simply say, "No thanks, not today, doc." Even if you are thin, this is an act of allyship towards those in fat bodies. There are clearly many opportunities for social workers to intervene at the patient and policy level in healthcare. For instance, we can screen all of our clients for eating disorders, regardless of their body size. We can advocate for our patients not being weighed, and we can recommend alternatives to weight loss for our clients. But how does the issue of weight stigma and discrimination relate to social workers who are not in medical settings? Let me give you a few examples. A shout out to Doctors Erin Harrop and Nancy Ellis Ordway for their help in compiling this list. In child welfare, weight stigma can look like social workers being involved with removing fat kids from homes due to a lack of weight management or weight loss. In hospice, weight stigma can look like social workers being asked to support weight loss regimens and forced dietary restriction in hospice care for older adults at the end of their lives. In addiction treatment, we often see concerns about switching addictions to sugar addiction or addictive eating, both of which have been debunked by science, by the way. Weight discrimination is rampant all throughout eating disorder treatment, with the under-recognition of atypical anorexia, people being bullied for weight in treatment centers, and people with atypical anorexia put on weight loss diets and not receiving nutritional rehabilitation. In mental health therapy, weight stigma can look like misdiagnosis or a social worker making assumptions about why a fat client is seeking services. Despite clinician assumptions, many fat folks are quite happy in their bodies and not seeking to change them. This can also look like focusing on weight loss with clients in mental health therapy, as this is beyond our scope. In school social work, weight stigma can look like social workers not intervening in body and weight-based teasing and bullying, something that fat children and teens encounter on a daily basis. Social workers working in eco-justice efforts have to confront the systemic exclusion of fat bodies from the outdoors via accessibility and equipment, for example. In macro social work, weight stigma emerges when social workers write policies and procedures for agencies and organizations that perpetuate stigma through harmful programs. For example, offering low-income populations cooking classes to address obesity, assuming these populations don't have the knowledge to eat well and that their poverty is causing their larger body sizes, rather than recognizing the impoverishing impacts of being in a stigmatized body. And finally, in our research, especially our research on health and health behaviors, weight stigma shows up all the time. From the calls for proposals on obesity, to intervention efforts focused on weight loss, to relying on BMI as a health outcome rather than measuring more equitable, pertinent outcomes. So, what can you do? While smashing the scale can be incredibly satisfying and perhaps even therapeutic, I might recommend it. It'd be kind of fun. It's not necessary. What is necessary is that you reflect on your own weight biases and weight stigmatizing practices and start to unlearn them. Here are some specific suggestions. You don't have to embrace the word fat in the way that I do, but when you use the word fat, use it as a neutral adjective. With clients, ask them what language they use to describe their bodies. Introduce them to the concept that fat is a word that we are reclaiming in our community. Avoid the words obese and obesity, and when you must use them, do so in quotation marks or with an asterisk in the middle of the word, recognizing the harm and stigma associated with these pathologizing terms. Avoid posting fat-phobic memes and articles on social media. This includes before and after dieting photos, or photos documenting your wellness journeys that focus on appearance changes. Be aware of your weight biases when providing peer reviews for conferences and papers. As someone who publishes in this area, I can attest to the stigma I often receive in peer reviews. Don't engage in diet culture with clients. Support your clients without supporting and promoting weight loss. Instead, engage your clients in critical conversations about fatness, misogyny, classism, racism, and the moralization of food and bodies. When a client approaches you with weight loss as a goal, explore the reasons they're wanting to lose weight. Perhaps they're struggling with body image. Maybe they're struggling with disordered eating or experiencing abuse. Understand that weight loss will not heal these issues, and focusing on it will soak up valuable clinical time. Promote fat-inclusive policies in your workplace. This can look like policies around size-inclusive furniture purchases, ensuring classrooms can accommodate fat bodies, weighing policies if your organization weighs clients, and health promotion policies. Don't assign value or morality to food. You don't need to earn food. You're not being bad if you eat a donut at a work meeting. All foods fit. Eat to nourish and celebrate your body and encourage your clients and colleagues to do the same. When needed, refer your clients to fat-positive or weight-inclusive colleagues in dietetics, eating disorder, and healthcare, especially if your clients are in large bodies. Know who these weight-neutral providers are in your community and utilize them. Read more on the topic. I suggest starting with authors Dr. Sabrina Strings, Dr. Nancy Ellis Ordway, a fellow social worker, and Aubrey Gordon. Avoid the use of the BMI, or body mass index, as it was designed using a white male European standard to be a population-level measure and is not appropriate for individual diagnosing. In other words, the BMI is used inappropriately, is systematically biased against many already oppressed groups of people, and is not a good indicator of individual health. And finally, join NAFA in their campaign for size freedom to reduce the number of states where fat and size discrimination is legal, because 48 is unacceptable. The QR code here takes you to their petition for size freedom. Thank you.